Good day and welcome to this Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us for this seminar. I'd like to welcome our web viewers and the Ontario Telemedicine Network sites as well. This seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to after the seminar presentation so that we can get a microphone to you. For our virtual viewers, please send in your questions and we will ask them for you. These seminars are hosted by the Waterloo Institute for Health Informatics Research, the Lawson Health Research Institute, and the National Institutes for Health Informatics. We are very grateful to our seminar sponsors, Healthcare Information Management and Communications Canada, McKesson Information Solutions, and ITAC Health. We could not host these seminars without their support. I have a couple of announcements today. Our next Smarter Health Seminar will be on Tuesday, November 24th. Our guest speaker will be Mr. Ron Dunn, who is the VP of McKesson Information Systems, and he'll be speaking on a view of the Canadian healthcare IT industry. At that seminar, we'll be making two important presentations that day, including the announcement of the first recipient of a medal for Canadian innovation in health informatics. So please be sure to join us. It will be a very special event. In addition, our next Institute Research Seminar will be on November the 10th, right next door in Davis Centre 1304, over the noon hour. And Professor Daniela O'Neill, who's an associate professor in the Department of Psychology here at the University of Waterloo, will give a seminar on the language use inventory aiding the detection of language delay among 18 to 47-month-old children. So you can see the diversity of the spectrum of interests that we have in health informatics. As many of you know, the Smarter Health seminars this year are focused on leaders in health informatics and e-health industry. We need leadership. We seem to be embroiled in controversy in healthcare, in health informatics, in e-health, how to go forward into the future. We have so many solutions that need to be figured out, processes to figure out, new solutions to problems that we have. So we are very fortunate to have leaders that come to these seminars and give us inspiration of how we can go into the future. Today we were to have Mr. Bill Tatham as our guest speaker. Unfortunately, Bill could not make it today, but that's not a problem because his associate, Dr. Kevin Leonard, has graciously stepped in to give a presentation on strategy for e-health innovation. They both share a passion for patient-centered care, and I can't think of a better person to give this presentation if Bill can't than Kevin Leonard. So the schedule for today is as follows. Kevin will speak for about 45 to 50 minutes. This will be followed by a facilitated discussion, and as I mentioned, please hold your questions to after the presentation and we'll get a microphone to you. And again, we invite our web viewers and teleconference viewers to please send in their questions. I'm now very pleased to introduce our guest speaker. Dr. Kevin Leonard is a professor in the Department of Health Policy, Management and Evaluation at the University of Toronto. He received his PhD from the Joint Doctoral Program in Montreal, where he specialized in statistics and information systems theory for business. After several years in the banking and credit risk industry, Kevin joined Wilfrid Laurier University as a professor in the School of Business and Economics. Then in 1996, Kevin joined the University of Toronto, and he has been pursuing the creation of a national patient advocacy program and researching issues pertaining to the development and implementation of a centralized electronic patient or health record since that time. What you may not know is that Kevin has another side to his academic interests. He has written numerous plays, skits, and comedy routines, all based on real-life experiences. He has performed stand-up comedy since the late 70s, beginning with winning the Concordia University Gong Show competition. There you go. He's had his comedy plays and skits performed in a number of avenues across Canada, including the Toronto Fringe Theatre Festival, the new Play Festival at Wilfrid Laurier University, and the National Arts Centre in Ottawa. Additionally, Kevin won third place in the one-act playwriting competition at Hart House University, at the University of Toronto. So I can't imagine what better way to have this presentation from a very serious perspective, and perhaps we'll see that comedy coming through today. So please welcome Kevin Leonard.
Great, thank you very much, Shirley. Number one, thank you for the invitation to come and talk today. It's my pleasure to be here. As Shirley mentioned, I am standing in for Bill Tatham, who's the Chairman and CEO of NextG Systems. Unfortunately, Bill can't be here today. I'm not here to replace him, but I'm here to give a talk in his stead. Bill is irreplaceable, so I'm not going to try and compete with that. I'll just try and give the best presentation I can. This will be a presentation, a blend of two different perspectives to some degree. As Shirley mentioned, NextG has developed a strategy for eHealth, and I'm going to present that, but I'll also flavor it with a bit of my own personal perspectives around patients, patient involvement, patient empowerment, and the role patients can play. So if I say anything that's controversial, it belongs to Bill. If I say anything that's controversial and wrong, it belongs to me. That way, hopefully, we curtail the lawsuits. All right. Why healthcare? We have a major problem in healthcare. Those of you that live in Ontario or familiar with Ontario know that we had an agency that received, shall we say, a lot of press recently called eHealth Ontario. And a lot of that press was around how contracts were tendered, how money was spent, and so on. Unfortunately, we lost track in a lot of the scandal and a lot of the innuendos and the writings around how important eHealth is. And my job today is to try and bring the eHealth focus on healthcare. Our healthcare situation today across the province, across the country, and certainly globally, it really can be defined by three different dimensions. First of all, quality of care. Do we have good quality of care? We could argue that for long past the 50 minutes that I'm supposed to be up here, into days and months and weeks, and we still would not get a really good consensus on what we define as quality, let alone whether we've achieved it or not. The problem is that we don't have a lot of really good outcome measures. We're getting there, we're working on it. In the last few years, there's certainly been much more focus on benefits evaluation and performance measurement, and how those indicate good or not so good quality of care. But we haven't arrived at that, an equation, a foundation that we all agree with. So that's one issue. We know that we want care, we know that care can be better, and we certainly have lots of instances of it, but it's hard to define it. And if you can't define it and measure it, then it's hard to work towards. So we have a quality of care issue for sure. Secondly, patient safety. I think it was groundbreaking work in the late 90s to Error is Human report that came out in the United States that first made a lot of attention around patient safety and adverse events and deaths related to adverse events. In the study, they created a confidence interval that said somewhere between 44,000 and 90,000 deaths in the US over 1 year could be attributable to patient safety errors. So in other words, adverse events or errors that could be classified as patient safety. That's a big confidence interval. So not only is the number scary, somewhere between 44 and 90,000, but the fact that we don't know what the number is even scarier. So we have a patient safety issue. One of the researchers in my department, Ross Baker, a professor in our department, has worked with Peter Norton and has taken on the Canadian challenge of to err as human and to cross the quality chasm and looking at patient safety. There was a quote of basically, every week, if you had a 747 crash, every week, that would be, over the course of a year, about the number of people that die in Canada from patient safety or adverse events. And that's an awful statistic to think about. I think the big takeaway with that is that we have a patient safety problem, and we need to improve it. And that really stems a lot from the first one around quality of care and defining it. And then finally, cost. Costs are escalating. I mentioned right at the very beginning about eHealth. eHealth is seen as something that can be introduced in the healthcare system cost effectively. In other words, improve the delivery of care, but also reduce costs. Costs are escalating. 32% of the provincial budget a decade ago was on healthcare. So in the province of Ontario, 32% of the budget went to healthcare. Now it's over 43%, close to 45%. It cannot continue. If it does continue, we won't have anything else in this province. So there won't be anybody sitting in here because we won't have any education. You won't be able to drive to work because we won't have any roads. We'll just have healthcare. And then even then, that'll start crumbling. And I know it sounds like rhetoric and fear-mongering, but it's really not. It's not unheard of or unthinkable to picture or imagine a healthcare in this province where you're going to go to the ER because you've been in a car accident, you've had some trauma, a heart attack, whatever, and you're asked to put on the table your OHIP card and a credit card. Now, you may have private insurance that'll do some coverage, but there still may be some back pay or copay that you would have to pay. And I'm not talking 2,500 years from now or 50 years from now. I'm talking within the next 5 to 10 years, that's coming. It's coming. So let's work on it now. You know, you always say, well, why did you wait so long to tell us? Why didn't you tell us when it was happening before it got to this point? Guess what? That's why we're here, to tell you now, to get your attention. So if I sound bold and controversial, again, it was written by Bill, but if it's wrong, it's written by me, but I do want to be bold and controversial. And hopefully we can engage in very good discussion. Okay, so how do we fix healthcare? We need a vision. If we're going to build and apply technology, and I'm talking to one of the world-leading institutions in innovation and technology, right here, University of Waterloo. As mentioned in my bio, I taught across the street at Wilfrid Laurier University. So I'm very familiar with the research triangle in Ontario here and this university. And if we're going to introduce technology, like anywhere else, we've got to know what we want the technology to do before we introduce it. It's like we're walking around with all these handheld devices and so on. I got lots of solutions. I wonder what the problem is. Well, we need some direction and leadership around stating what the problem is and how we're going to fix it. There's not only one vision. I'm going to propose our vision, what we're doing and how we're approaching it. You may say, well, here's another vision, and that's fine, and we can debate that. But we need a debate around the vision, and then we need some consensus, and then we need to build towards it, whatever that is. Every man for himself, okay, that could be a vision. It's not great, but that may be where we want to head. But at least we know where we're headed. Our vision is one patient, one record. The patient is really the only reason we have a healthcare system. And sometimes I say that to people that are in healthcare and been working in healthcare for 20, 30 years, and they said, you know, I never really thought of it that way. The patient is the only reason we have a healthcare system. If there's no illness, if there's no trauma, there's no need to make people better. People don't get sick. We don't have a healthcare system. We don't need it. The doctors should be retrained, do something else, close all the hospitals and so on. That's not going to happen in our lifetime. That is rhetoric and some sort of an unimaginable future. So given that we will have the need for healthcare, how are we going to organize it? Well, right now, all of the data, all of the processes, and dare I say, all of the information systems are organized around institutions and stakeholders, except for the one stakeholder that really matters, the one stakeholder that drives it all, and that's the patient. And if you don't believe it, then you can go to the Ontario Laboratory Information System and find a database organized and compiled of lab results in the province. You can go to the Ministry of Health and find out all the people that used their OHIP cards last year. You can go to a clinic and doctor's office and find out all the records for that doctor. And you can go to an adjacent hospital and find some of the same patients in that filing cabinet as well, and on and on and on and on. Now, in a small system, paper-based, isolated and fragmented, it's not that big a deal. If it's flush with money and we don't mind duplicating all sorts of stuff, then yeah, we'll go ahead with it. But as we start to get the crunch and we want to figure out how we can do things better, then we need to move from paper to digital, and we need to think about how we organize that digital record. So our vision is one patient, one record. And that means when I go to see my physician, when I go to see my specialist, when I go to see the chiropractor, the dentist, my family member, circle of care, caregiver, we all have access to one record. That's my record. It's full, it's complete, and it's as accurate as I can make it. Because nobody cares about my healthcare status more than me. Now, you can argue that you care as much as me, but you can't argue you care more than me about me. And I can't argue that for you. So who wants the information and the data that's in the file to be accurate any more than I do? I want it right. I've got food allergies. I want that accurately documented in my chart. So one patient, one record, share the record with the patient. And be able to use that information to help in managing your health care, in getting well, and being and staying well. That's a critical point. Physicians, public health, say we have trouble reaching out to people to stop smoking, watch their diet, lose weight, exercise more. I was, when I was practicing this talk this week, was going to throw in, get people's awareness to the H1N1 virus and the vaccine, but I don't think we have to worry about that. It seems like everybody's aware of that. But there isn't a strong relationship seen. It's not obvious for the average person that if you have this amount of extra food, that many more calories every day, that it'll have this effect on your health 5 years down the road. If you have this much intake of tobacco every day, it'll have this effect in 20 years. We don't have that. It's hard. If cancer from cigarette smoke was immediate and all the time, we'd have no smoking. If you picked your cigarette up first thing in the morning, the first time you ever smoked was 8 o'clock in the morning, and by noon you had cancer, trust me, no one would ever smoke. So the relationship between the action and the reaction is obviously, it's fast, it's clear, people don't do it. We got to use technology, and that's an oversimplification of it, but we have to use technology to help people, to coach them, to say, these are the kinds of things that happen when you do that over a long period of time, and to start changing behavior. Okay, next-G systems. If I was Bill now, I would talk about next-G systems. I'm going to be Kevin, so I'll talk about how I got to know next-G systems. I'm a patient. I have Crohn's disease. This year, I am celebrating my 40th year with Crohn's disease. Trust me, it's a weird celebration. And Crohn's disease is an inflammatory bowel disease that really affects a lot of other things. I know you think the scar on the forehead is actually my Halloween mask. It's not, but it's a result from some skin cancer that I had removed late last week. But that was from reaction from meds and medication that I take. But as a patient, I've been pushing more involvement because I know what the benefits are for me when I manage my care. And when I say manage my care, I don't mean I fired the doctor and I don't go to the hospitals anymore and I drink this herbal tea and this magic pill and blah, blah. It's work, but it's work with the system, with my providers, with my nurses, with my doctors and specialists. They need to know what's going on with me. Often I'll get sent to some specialist that I've never been to before and may never see again because of some flare-up. I had problems with my kidneys once, so I had to go see a kidney specialist, nephrologist. And I had to spend the first hour giving that doctor my complete medical history. Number one, it probably wasn't complete because I'm sure I've forgotten a lot of things over the years. Number two, I probably got it wrong. And number three, why are we wasting all that time when everybody knows me? It's in the file, just check. So the key is integration. NextJ systems and Janus systems that were founded in the 1980s and 90s and sold from in the early 2000s made their mark in financial sector, but customer relationship management, CRM. And there, the philosophy was, how do I put all the information I have about a customer or a client together in a view to support decision-making around financial, investors, insurance brokers, and so on. So the people at NextJ thought, well, how is this any different from a provider? And from my perspective, how is it any different from a patient? I've got to get information from a lot of different sources. I want to put it together in neat, creative ways that provide decision support for me, for my provider, for the doctor, and help them make optimal decisions. We, in the university world, are always worried of being obsolete, irrelevant. Well, we have ways using certain types of expert systems and alerts and so on to have our research inform these types of models. So they're no longer buried in journals and periodicals. I mean, I had a supervising professor when I was doing my PhD, and he said, congratulations on getting your first article in the European Journal of Operations Research, one of the top-tier journals. He says, now you're guaranteed that over the lifetime of this article, 2.7 academics will read it. And I'm not sure he's wrong. We've gone a long way from that. We have ways now to make our research relevant by being involved in this next wave of research and implementation. Okay, NextJ. So here's a firm that has tremendous capabilities in bringing in data from a variety of sources and helping to get a comprehensive view. It's going to help me make the argument because I say I want all my information together, and I'm barely getting physicians today to use electronic health records, electronic medical records. So if they're not using it and it's not going into digital, then how am I going to get it? So we need to partner with people. The solution to eHealth, is not going to happen on Bay Street, 777 Bay, which is where their address is. And it's certainly not going to happen at the Ministry of Health in Queen's Park across the street. It's going to be a lot of people doing a lot of work. We need vision, like I mentioned before, and we could argue whether our vision is right or wrong, but we need a vision. But we need partners. Von Glover and Bill Tatham together formed CAPCH, which is a Canadian Association for People-Centered Health. This is an organization that is promoting people-centered health. Now, we're going to come back to that term because what does that mean? And I got to tell you, we have debated people-centered health, people-centered, centered health, people-centered health, and all those terms forever and ever and ever. So I don't want to do that today. But it's a concept that I think whose time has come. Von Glover, in fact, today is in Nova Scotia talking to the minister and the Ministry of Health there to promote this concept. And the concept really is that the patient is the center of the healthcare system. Now, if you speak to people individually, sure, the patient's the center. But there are words and there are actions. And if the information system isn't organized around the patient, if the patient can't access information, if the patient can't make decisions, then I challenge whether it really is people-centered or patient-centered. We're also working with a community of health professionals, developers, organizations under the umbrella of open health tools. So these are a lot of successful organizations like NextJ that are offering their software and their architecture on a no-cost, open, free source, open source venue. Here, use the code. Let's try to get from where we are today in the sparse use of electronic health tools to having comprehensive electronic health records. And also I want to talk about an initiative that is ongoing, that we've launched in the last number of months at North York General Hospital, which is a community teaching hospital in North York, just north of Toronto. And a new research and innovation center that's being started there, and the research that we're doing now. But I want to emphasize that this is not me telling you what I'm doing, telling you what we're doing. This is a pitch for you and us to work together. This is our chance to get our research really relevant. This is our way of making a change. So if I wander too off into, it sounds like I'm preaching or I'm telling, it's really an invitation. I don't know if you saw the movie Milk, but in there he says, "My name's Harvey Milk, I'm here to recruit you." Well, my name's Kevin Leonard, and we're here to recruit you to the eHealth initiative, people-centered health. Okay, so who are some of our partners? Now I have a time limit, and if it was up to me, we'd be here about 10:30 ordering pizza and so on, but it's really not up to me. So I'm going to keep wary of time. But I want to talk a little bit about who are some of the partners in this program. We have, under the auspices of CAPCH, Canadian Association for People-Centered Health, a number of academic institutions that are involved now, that want to promote people-centered health. So what's the tie-in? Is it eHealth? Yes, it's eHealth, using eHealth tools, but it's not tools, solutions looking for problems. This is tools used in conjunction with achieving an objective. And the objective is having the patient more control, more involved, the center of the healthcare system. I'll get into a little bit later where some of the research has shown and why it's so encouraging to do so. But some of our partners are listed there: York University, University of Toronto, University of Waterloo, George Brown College, North York General Hospital, the Michener Institute, Carleton University, and Mohawk College. These are our goals. Our objective is this people-centered health. We want to evangelize, we want to promote the research, perhaps even get into accreditation. Is your organization really people-centered? I go to a pharmacy and the pharmacy says on its bag, leader in people-centered health or patient-centered health. It isn't. It says it on the bag, but it really isn't. So we need to know what those terms mean, and we need to know, how do I achieve that? Because you can't say you are, you aren't, if you don't help people move from one to the other. And certainly involving consulting to help that process along. Raise awareness, improve the quality and safety, evidence, the research evidence, and ultimately improve health outcomes. If what we're doing If all this investment in eHealth, if our goal for one patient, one record, if our goal for people-centered health does not improve health outcomes, real health outcomes, then we should forget it. It's just a waste of time. We should be doing something else. That's our objective. That's the business that we're in. If you're making widgets and you make a change to the manufacturing process and somehow you improve people's health care, but the widgets stay the same, you wouldn't continue to do that. You'd do something to improve the widgets. Well, our job is to make people healthier. We need to identify some measures, but that's got to be the end game. Are we making people healthier? And how do you define that? Those are not easy questions, and those are some of the questions that we'll get into in a discussion in the Q&A. NextJ, and the reason that I'm here today and I work with them is because of the facilities that I mentioned earlier, the ability to integrate. And their whole process is driven by, or under this philosophy of model-driven engineering. And basically, it's easy as 1, 2, 3. And the first step is, what's my application? What am I trying to do? Second step, I don't want to rebuild the database, because if I do that, that's going to take forever, and that's not really attractive. And thirdly, how do I deliver information out? So we're just now, as an industry, getting more and more digital records. We still have family docs, about 20-25% across the country, different regions, and this region is much more advanced than most regions in the country, have moved from paper to digital. The paper to digital, as I said before, is really not a big success. I mean, it is successful and you can get at some information faster and organizing it better, but the real power comes from moving it around, integrating it. And that means we need some way to do that. And if you think about all of the systems and all of the money that has been spent already, ripping it all out and starting from scratch is not a solution. Well, it's a solution, but it's not a viable solution. It was one that was tried in Britain and the UK and has proved to be extremely costly. So let's assume that we don't want to do that. So if that's the case, then I've got either systems that are still in paper, some that are in the process of moving from paper to digital, and then there are some that have moved to digital and electronic records. Well, we need to use this type of philosophy to leverage the connectivity across the different parts of your organization so that a physician can talk to a patient, can pull in a lab result from perhaps a lab that was not affiliated with his or her own clinic, or maybe it's a doctor in a hospital and an external source, can pull up data on the patient and be able to give that information to the patient so they can do something with it. Sometimes right there in the office, maybe even send them an email. So we don't have to go and be face-to-face with the providers all the time. And that's really where one of the system wins are that I want to sort of point out as we go through this. One of the big wins is that we will move information around like we do in every other industry, as fast as we move information around. So you can buy airplane tickets, do your banking. We all know those great examples. But right now, we move information in healthcare as fast as we move the patient. That's the speed at which we move it. How do I know? Because I bring it with me. A friend of mine, works in a landscaping company, but he's a big golfer. Up in Collingwood, had trouble with his wrist, came all the way down to Toronto, waited a full day to see a specialist. 4:45, specialist comes out and says, okay, where's your x-ray? What x-ray? Well, they did a test on your arm and they sent you here. Where's the results? I didn't know that. I said, well, how are we going to get it? Well, can't you just sort of dial in and get it? And this is a guy that's not stupid. This is a person that's in his 40 to 50 year range and expects that information to be there. Well, I'll give you my account number if you want at the hospital. So he couldn't get his treatment done at all because it was too complicated a procedure. He had to get a dye and everything else. So he had to reschedule that and come back down with the x-ray another day. So on his drive from Toronto up to Collingwood, who do you think he was on the phone with? Cursing me, because he figured I was the one that screwed up all the eHealth stuff. But that's the assumption that we can move information around. We can't. So we want to get that big benefit from moving from paper to digital. How do I move it around faster? It really begs another question, and that is, does this affect the payment model, the reimbursement model that exists today in the province, in the country, and elsewhere? And the question is, yes, it is at great odds in some regions. There are a lot of roster capitation programs in this community. So your doctor is paid to keep you healthy. So he doesn't care if he sees you or not. He wants you as healthy as you can be. That's his objective. He keeps you healthy. Everybody's happy. Unlike the old model of fee-for-service, which was come in here, we'll have a chat, send you home, send you for blood work, come back, we'll have another chat, back, and reinforces the whole wrong message. So it's a big problem because you've got to fix a lot of different dimensions. Okay, so we're going to talk a couple examples on this, what we mean by model-driven engineering. So here's the NextJ suite. What's that? Okay, so the first step is, how do I integrate data from a variety of sources? I have a physician that's a hematologist. On staff is 2.5 FTEs. All they do is talk to all of the other clinics and labs in the city to get emails and faxes so that their staff can get it and then re-enter it into the Toronto General Hospital information system because he can't import it from anywhere else. So he's got blood work that I do there, but if I do blood work anywhere else, he's got to go and get it. So his roster of patients is so big, it requires 2.5 people. Now multiply that by every hematologist, and we're into big savings. Forget about all the other services and all the other doctors. But it's not a simple problem. If it was simple, we would have done it. We would have done it if it was just a matter of throwing a lot of horses at it. It's more than that. It's complicated in terms of energy, but it requires some sort of sophistication in terms of technology and architecture. So NextJ has created this universal health connector, which means I'll take data from anywhere. Is there programming involved? Yes. Does the first time you do it take longer than the next time? Yes. But the time after that is less and less and less, and it's extremely scalable. So number one, I can get at information and bring it. Then what am I going to do with it? Well, I need to somehow merge this information in some comprehensive view. If it's just going to be pages and pages and pages, like a PDF, then we don't need any integration either. But that's not where the power comes. The power comes at looking at your blood work over the last 18 months. We're doing a project right here in this LHIN, looking at the benefits that stem from patient engagement and patients having access to their health information for diabetic patients. And the real power is for them to go back over the last 18 months, plot their blood work and find out where their sugars were high or low, and remember and perhaps even have a diary of sorts, what their diet was, what their pill regimen was, when they took this, when they exercised, when they took their measures. Patients that have a chronic illness, like me, we call them the 3 Cs, consumers with chronic conditions. We're big users of the healthcare system. 33% of the population, Canada, Ontario, globally, it's about the same, has one chronic disease or more. but we account for about 75 to 80% of the spend. So 75 to 80% of the time, the healthcare system is treating me. And trust me, there are days when I feel it's just me. But we want to use it less. How do I help you manage it with me? Not alone with me, but together. Okay, so that means providing information in a comprehensive view in the sense of providing it back to the provider. The middle column there is sending it back or allowing the consumer to have access to it over a web, over a secure portal, or perhaps even a mobile environment, a wireless, handheld device, where you get alerts to check your blood sugar, where you get your alerts to check your weight, you haven't checked it in the morning, your blood pressure, and so on. There's lots of great research projects now that are going on to hopefully help inform where you put those alerts and what those alerts are. Because there's no magic book, regardless of what you hear about Wikipedia. There is no magic source that'll say, if this and if this in terms of readings, then this is what the patient must do. And it's often individualized and so on. So we have the three platforms to present the data back, and then what we want to do is be able to start looking at outcomes. How do we help people make decisions and then measure how well they work? So we need to do some stats in terms of prevalence and incidence, but also in terms of outcomes and creating evidence. So people-centered health. I mentioned the three columns before, so here we are sort of blown up a little bit. We have a provider portal that allows, again, for the patient, all in the patient view, allows the provider to have access and perhaps to prescribe, either send messaging in a secured sense or secured method rather, or to act as a coach. We have the family or the patient first in their circle of care, could be neighbor, could be friend, could be family member. And then also even throughout the course of the day, on the road, in action, on the wireless device. All of you are, I'm sure, given RIM in the neighborhood, have some sort of handheld email device, always checking it, had to change the driving rules in the province because of it. So we're used to that. What happens if we can somehow help people make the decisions and shrink that time frame from a bad cigarette habit over 30 years down to that example that I said of one cigarette, but maybe shorten that time frame a little bit and coach them about their overall health and well-being. And to do it, requires some sort of behavior change. The first behavior change, really, one could argue, is to get patients involved in managing their care. If you're healthy, you don't have a lot in your health record, there's probably very little motivation for a large percentage of the population to look at their health record. But all of us should be motivated to stay well. Okay, so in our example here, and we can go through this quickly because we still have a few more slides, and I think I have to wrap up sometime around 4-ish, right? So let's assume that we have a patient. The patient is Michelle Gibson, receives messages from her doctor. Doesn't have to be in a handheld, could be an email, whatever. She can upload information. We have the technology available today to have devices Bluetooth enabled. So I'm involved in one project that UHN, one of my doctoral students, is looking at heart failure patients and wanting to make sure that they take their blood pressure and other measures throughout the course of the day. And if they don't, they'll get messages. They'll get an email or a phone call saying, hey, we didn't get your weight today. So this is a way to go through a lot of data and provide a help. We can have interaction with family members. One of the things that we've talked about is using the camera phone, taking a picture of your meal. Perhaps if you did that all the time, you wouldn't have so much fries and more salad, who knows. And then the personal health coach. And you can actually say at different points in time during the day how you feel. Here's the picture of the food, see? And how I feel, and describe it in terms of, I don't know, icons or images or whatever. So it goes from, wouldn't this be a neat idea, to, here, we have these devices, we have this technology. Let's use this technology to help people stay well. So it's not just about getting people that are ill better, or get people that have a chronic illness and maintain their illness, but it's also everyone else that's healthy and well to stay healthy and well. There are programs in different countries. I know South Africa had a points program that was tied into something like a Shoppers Drug Mart would be here. And if you bought certain food, if you followed certain health management patterns, you would get coupons or gift cards or points that would then be used towards purchases for other health style products. I mean, we're a society, I think, that's we've got points on everything. I'm the only person, I think, that doesn't have loyalty miles program, the LMG. But I think every other 33 million people in the country has one. It must be, because when I say no and they ask me, they look at me like I just got off the bus from somewhere. Okay, but this is the power of moving this information around. There's a lot of talk around individual, or what we would call untethered, patient portals. What I mean by that is you buy a software, you put it on your desktop, and you do all the entry and management yourself. So there's some benefit to that, and that's like moving from your own personal plan to a desktop personal plan. But if you want to engage all of the health information that you have, some blood indicators, some lab results, and so on, then you need to integrate with other sources. And the best source of health information about you is either in your doctor's office, the clinic office, or the hospital's office. And you want to be able to link that. You want to be able to have access to that. We had a symposium in April called One Patient, One Record. And perhaps I'll be back someday and we can chat about how that symposium was. But basically, there was over 100 people and well over 50 patients in the room. And we asked them, should you be able to have access to this information that's about you? And they all say yes. So we have half patients, half providers. Then we started debating questions. Should you have unfettered access? In other words, should you be able to get access to your health record without the doctor's approval? Over 95% of the health professionals in the room, doctors, administrators, and so on, they all said yes. Yet only around 85% of the patients said yes. So less patients think they should have unfettered access than physicians and other professionals. Luckily, I followed the suggestion of our symposium coordinator and added a few lines around comment. Why did you vote yes or no? And of course, what we found out was patients that voted no were worried what that really meant. Does unfettered access and me having a look at it without the doctor meaning the doctor will never look at it? Am I alone here? Is it up to me to decide if I'm beyond or above a threshold? That was a very scary thing for them. So we know that patients want to have information, they want to be able to do this, but they don't want to do it alone, which is why we need to integrate data, move it around, and involve other participants. We need to integrate data so that there's perhaps a physician, perhaps it's a dietitian, a nutritionist, some sort of health coach that can help you interpret a lot of this data. Because most patients, and if we're looking at early adopters to this, will be patients with chronic illness, are well versed in their own illness. They're not physicians, they're not going to be able to start treating everybody, nor could they treat other patients with the same condition probably, but they know their own selves. They know their own bodies, they know the indicators. And with some right coaching, we can allow people to take more ownership, and they want to take more ownership. And I think that's a key message. They really do. But we don't know how to do that. We are, okay, getting close, okay. Well, there's two projects I want to talk about. One is population-based disease screening. When eHealth Ontario, just around the time that the whole audit hit and everything else, they had launched just before that. They had done some work around creating a strategy. You can argue whether you like the strategy or not, but they did come up with a strategy, and one of the strategies was come up with a disease registry. And because of diabetes and its popularity and how many people have it, and the potential for gain, they wanted to build a diabetic registry. Well, that helps you identify who has diabetes. So if you want to send out reminders about eye exams, foot exams, and so on, and getting your hemoglobin A1C, you've got to know who has diabetes. One level before that, there are people that have illnesses and we don't know they have them. And we all do know that just about every illness is more treatable the sooner you get it diagnosed. So we have the ability to do some disease screening. To work with, we're working with one of the provinces to do a colorectal screening. And hopefully increase the number of cases diagnosed and the health outcomes. And that's where it comes back again to health outcomes. We were also involved in a project in Jane Finch, which is a neighborhood that's near North York General Hospital, and engaging the patient with their own BlackBerry and being able to monitor some of their health indicators and give them feedback, as I mentioned before. Okay, so let me just talk a little bit about this academic research collaborative, because it ties in where I was at the beginning and where we are today as an organization and as a research collaborative. There's a number of people that are involved. You can see the names of the different organizations. I've referred to some already during my talk. This is just the first wave of people that want to be involved in our academic research collaborative. As it pertains to eHealth, yes, but eHealth applied to people-centered health and people-centered health objective. A lot of you are working on projects, research projects in healthcare, and we want to work with you. NextJ has already dedicated $9 million in funding to start a lot of the projects that I mentioned. We really didn't have a lot of time to get into the detail of projects, and hopefully some of the give and take and question and answers, we can do that. But that's the kind of leadership that we need. So it's not just identifying, it would be good if we had a different paradigm, but this is the paradigm we believe is going to work. And we're committed to doing it, and we've started doing it. And we want your help in doing it. I mentioned earlier about making your research relevant. There's all sorts of ways. I try to identify during the course of the talk different places where your research can become relevant in providing alerts, in providing best practice, in training, in interpreting results, in behavior change. There's no shortage of different dimensions that you could look at where we need research from a lot of different disciplines. It's not just technology and computers, and it's not just healthcare either. But how do we get people motivated to become more involved in their healthcare in the first place? And I know it sounds like a straightforward argument, but it is. It's a difficult message to communicate and to have a lot of strong uptake. Okay, I'm getting close to the end. 5 minutes? Okay. Okay, so we have the NextJ eHealth suite of projects. I've talked a lot about a number of different things that we at NextJ are doing in eHealth and in healthcare and in coaching and in outcomes measurement and so on. You see a number of different projects that are listed here. These are projects that are not planned for 2011, but these are projects that are on the go now. I mentioned that we've invested $9 million in funding to get these projects up and running. And funding to get it started so that we can measure a lot of the outcomes. That analytic server at the end, or the second to last bullet, is critical. It's very easy to build systems and not put measurement evaluation in it. It's very easy to do consulting and not put measurement in it. How well was this consulting advice? Or IT projects anywhere. But we know we have to do that. Why? Because these are projects that we want to showcase functionality, how they can be implemented, all of the issues that surround the implementation, and most importantly, what are the benefits, what are the outcomes that stem from it. Some may be unintended consequences. The literature now in the last few years has shown a lot of unintended consequences, publications around physician order entry and different types of eHealth tools and so on. So we know this will be no different if we're introducing tools for the patient, integrating a comprehensive patient view across all provider portals, all provider databases and so on. We know there will be some unexpected outcomes. Some will be good, some won't be. But we need to measure that. Okay, so at North York, and I mentioned that earlier, we've established this North York Research and Innovation Center in collaboration with North York General Hospital. This is a partnership between the CAPCH, Open Health Tools that I mentioned in the slide earlier, York University, and NextJ Systems. And we really want to create, as it says there, a global center of excellence in family and community health, eHealth. It's not eHealth for eHealth's sake, because the outcomes will be health outcomes. There will be some eHealth outcomes in terms of processes and other types of efficiency gains, but really big win health outcomes. Does improving information flow make the patient better? We hope so. Establishing a living lab to apply and commercialize this research. So I come back to my point earlier about making your research relevant. So if you've got ideas, if you've got theories and hypotheses, not only is this an environment that we want to promote and try those different types of strategies, but also be able to commercialize the ones that are very successful. this region, this university has a history of doing that, a strong history. And one way of doing that is partnering, as I mentioned, with the open health tools and using open source code, open source documentation to help us with that, so that we can create this cycle where hopefully we're fostering innovation, we're focusing on projects, drive commercialization, and then establish the global leadership. And it's all of it that's important. It's not just one piece of it. So we've covered a lot of ground. I know we're getting close, and hopefully we'll get some question and answers. We covered a lot of ground. So just to recap, mainly, is we have a healthcare system that needs change. Change, efficiency gains that can be gained by applying eHealth to solutions, or eHealth solutions to problems. But to do that, we need a vision of what we're going to build. Our vision is one patient, one record, people-centered health. People are at the center. And then use tools and technology to integrate the resources that are around the patient to allow the patient and their coaches and their partners and their providers to enact better health decisions. A lot of that data exists. We say that we're worried about patients understanding the interpretation of a blood result. There's lots of data in different databases, some better than others, of course, that define illnesses, define different types of treatments, options, outcomes, potentials, and so on. That can be incorporated. So that part is there. We don't need to rebuild a lot of that, but we do need to access it and integrate it, and that's where us working together has got to come in. It's all of us together, hopefully, we can get a sustainable eHealth innovations. Okay?
All right.
Thank you.
Thank you very much. So we'd like to start the question and answer session now, and maybe we'll start first with a question from the web, and then we'll, while the audience is thinking of their questions as well. So can we get a mic to Martha, who will speak one of the questions from the web?
Hi, I have a question from the web. How does the model you described address privacy and security?
How would the model describe?
Privacy and security.
Okay. Privacy, I mean, that's a great question to start with. Privacy is a big issue. First of all, the system we have today is private by accident. We can't find data. That example of the landscaper from Collingwood, his information is secure. Ain't no one breaching that file. Nobody could get at the file, not even him. We do have privacy issues on the ward, and if you don't believe me, go into any hospital, get a white coat and stethoscope, go in and say, I'm the doctor here to see Kevin Leonard, blah, 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 blah. Next thing you know, you got the file. Or just walk in to visit someone in a ward, and you see listed all the names of all the patients there. So we have privacy issues today. So we don't have the perfect solution now, and then we're walking away from it. So I want to make sure that message is clear. Secondly, privacy specifically is about keeping my information to me. I have no control over my information right now. As I mentioned to you before, I have a long history of Crohn's disease. I went down for an ultrasound, opened up my chart while I was reading it, and the technician for the ultrasound came out and said, "What are you doing?" I'm looking at my file. "You're not allowed to do that." "Well, why not?" "Oh, you're not allowed." What could happen? Bad things happen when patients see their file. And then I went on to this whole thing about, do you know who I am? And of course she said no. And that hurt me more than anything. But that's the thinking. So we want a system where patients can control, or first of all, have access, equal access, just like anybody else does. So that's number one. then we need to have some really good discussions about whether some things should be able to be kept secure from providers or not. It's a really good discussion whether an emergency physician needs to know if you're there unconscious or semi-conscious, no family member, whether they need to know all the meds you're on or not, or you don't want them to know you're on this for depression or whatever. I mean, that could cause life and death outcomes and wrong decisions being made. So I'm not here to preach one way or another, but at least a system like this gets us talking about that question, which is what we need.
Okay.
Sorry. I have from Dominic too.
Okay, one question. Dominic, of course.
From Dominic. Tell us a bit about the challenge of getting innovations like NextJ's into the healthcare system. Has it been easy? What are the barriers? What is NextJ doing to overcome the barriers?
I told Dominic to ask me that when we were at the bar together. That's not one I can do sober. It's extremely difficult to bring new solutions from new entities into an old problem. You would think it would be the opposite, right? This is an old problem, so it's been around a while. So all the old people and the old methodologies ain't fixed it. So if it ain't fixed it, why don't we go to new people and new methodologies? You would think that would be fairly obvious. But no, there's a large resistance. What have you done? Who are you? So the first question is gaining credibility. I know Bill, when he first got involved in healthcare, he was hit a lot with, what do you know about healthcare? You're from financial services. Well, first of all, he's addressed that because he's invested so much time and energy in educating himself and his company and his partners around healthcare. But that's a crazy way to look at it in the first place. My background and training is from a business school, as you mentioned, banking and credit. That doesn't mean we don't need some of that expertise. We do. We need some of that thinking from other fields and other industries. We need to know that healthcare is different from every other industry, yes, but that's why you want partners. So I think the way we're trying to address Dominic's very appropriate question is through partnerships. And you may not know them, but they bring this, and you don't know them, but they bring this, but you do know me, and I've seen this, and I've seen that, and we've studied this, and we're also working with that guy over there and this person over here. No one company, no one place is going to come up with this solution. It's got to be a collaborative. And that will require some very new people and some very new ideas. And if you can't get your head around it, then, just get out of the way.
Can you give some examples of returns on investment? Some sort of examples that you might give to prove what your credibility, basically.
Okay, in terms of the technology, you mean, or? Okay, well, I could give you lots and lots of evidence. Again, most of the evidence that exists today are from projects, either research projects or pilot projects. So there's no place globally, now this is going on the World Wide Web, right? There's no place globally that can give a patient a comprehensive, full life-to-death record all in one. There are some countries that are very close, much more advanced than we are, but nobody's got the Holy Grail yet. And there's issues, many issues that we've touched on before. But we've seen tremendous, and there was just a paper just came out in the Journal of American Medical Informatics Association that echoes exactly this. And that is that there's a number of improvement in health indicators in terms of lower length of stay, lower readmit rates, and lower duplication of services. I was involved in a study, well, we're still trying to get it written up, here in Ontario. And we looked at hospitals and said, how much have you adopted technology? And we had a 95-point questionnaire, so a very detailed questionnaire on over 8 different dimensions. And from that, we then matched it with performance that another group did, the Hospital Report Card Series. So this is independent data. So not me fixing the numbers, but independent. The hospitals that are more advanced in using technology have lower length of stay, lower readmits, and readmits are defined as a patient being readmitted within 30 days for the same diagnosis. So in other words, they went home too fast. And lower duplication, which was looked at as x-rays and a few other routine procedures, blood work and so on, that happens when you come to the ER. So in other words, you're back? Oh, we have your stuff. As opposed to, could you fill out the flip chart, cough into your elbow, and we'll see you, which is sort of what's happening. So there's lots of great research. Now, I'm going to use your question. I'm going to just spin it a little bit, if that's okay. A lot of people say, well, you know what? You mentioned before about patients having unfettered access. I'm not sure that's a good idea because nobody wants to find out they got cancer over the internet. And that's the big thing, and then we all go off to lunch. And then we never have the meeting again. Well, what we found is that by accident, it has happened in a number of different settings. Not that they wanted to promote that, but because of timing and everything else, it's happened. And when you speak to the patients, well over 90% of the patients say, I wasn't happy to read that. But if my doctor told me I wasn't going to be happy either. And when my wife found out she had breast cancer, the doctor didn't tell her to bring her husband in because he didn't want to scare her. So she got the big surprise right there. And then once she got the diagnosis, she didn't hear a darn word. She had to go all the way home. And then the discussion with the family, what did the doctor say? I don't know, I didn't hear anything after the word cancer. But the patients that got notified, they were able to look up on the web, call people. They were able to connect because of the system that they were using with their provider. Say, can I have an appointment tomorrow? So within 24, 48 hours, they were able to see someone. So that's important. I don't want to minimize that. But they were able to get the questions out. How far advanced? Where are we? What are the treatment options? What about this drug? I got a neighbor that's down the hall, whatever, and they took that. Are they going to try that? Much more informed, positive discussion. And they weren't there alone. And that, they said, was the most powerful, that they were able to have a caregiver with them. And so when we do these measures, the measures are not just about health outcomes in terms of objective numbers that I mentioned, but also satisfaction. Satisfaction from physicians, satisfaction from providers and patients. And Jay Mercer, who is a physician in Ottawa, he wrote a great paper I think it was last fall, or maybe it was early part of this year, around his experience in engaging patients. He's a family doctor in Ottawa. And overwhelming stories of how positive it was to engage the patient. Is it easy to do it first? No. But certainly, there's many more positives than negatives.
Where do you see NextJ's solution deployed, and who are your target customers? For example, is what you're proposing something like a province-wide health information exchange or RIO? Is it like a national? You had a picture of NHIN. Is it like a national-wide, something like in the U.S. an NHIN? And you've also had stuff from the consumers. So is it something like Google Health, and are you selling to the consumers? So what are you actually targeting, and
Right.
who are you selling to?
See, my answer to that question would be yes, everything. But I think you want something a little more detailed than that. We know, because of Dominic's question, that introducing innovation into healthcare has not been easy. So we need to look at this from a multi-pronged approach. In other words, it's a big war, and we're going to have to fight battles on a lot of different fronts. One battle is to educate people, patients. Say, you need to be more involved in managing your health care. Would you pay $10 for a month to be on this a system that could support the kinds of things we're talking about? Maybe, maybe not, I don't know, but that's one thing we got to reach out to. We need to show functionality. We need to prove to physicians that when you do integrate all of this stuff and coach the patient actually responds positively. And it makes you feel more effective as a coach or a physician. So We want to do projects that are one-off in different regions and different areas. But it's also something that can be applied to the province or any large jurisdiction, such as a LIN or a country or whatever. The question is, what's the payment model? How does that work? And that's an interesting question, but my job, when I put up here, talked about analytics server, my job is to help identify those outcomes. When someone earmarks 1.9 or $2.1 billion to eHealth, what's happening to that money? Is that supposed to be money that goes in, you buy computers and it's over with? And then in 3 years' time it's obsolete and I need more computers, so where's the next check? Or can we use that money as investment? Can we say, give me 100 million, give me 300 million, and I am going to create a system so that next year's system, the overall health system in the province of Ontario, costs $300 million less. So we have a break even, and then a go forward flow. I truly believe, and I know it's a stretch, and it's Friday afternoon and all that stuff, and I've had surgery on my head, but this will dramatically change the way healthcare is delivered. In the university, if I take 2 seconds, 25 years ago, I was an undergraduate student, and I had very little say in anything. When my courses were, how I registered, I didn't like the prof, too bad, didn't like the midterm, too much reading, blah, 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 blah. Nobody cared. 25 years later, completely different scenario. We've gone from the stage on the sage to the guide on the side. Faculty, profs, teachers, we're there to help you learn so that when you leave, you continue to know how to learn, because all the learning doesn't end because you got a degree. That's the kind of message that we need to have. We need to look at how we can provide that kind of support going forward.
Hi. You've laid out a sweeping vision here. Are there any competing visions, and how do we stack up against the competition?
Okay, competing visions. Part of the problem with, we can talk about Ontario because we're in Ontario, okay? But part of the problem in Ontario is we don't have a vision. We don't have a vision. If we're going to have a vision and say, for example, it's one patient, one record, and someone says, no, I want, a different type of vision where everything's on a health card or everything's fragmented. I'm not sure because I'm extremely biased. But at least it's a vision I can debate with you one way or another and say, this is how we have to then restructure, reconfigure, and start to build out our healthcare system. And then we can plan for the savings that I talked about and the lifelong learning and all of that. If one of your strategies is to build a diabetes registry, for example, what about the other 299 chronic diseases? When do we get to the portal for Crohn's disease? And I know, it sounds like I've got an axe to grind, but when does that happen? And the portal for diabetes and Crohn's disease are going to be different, content-wise. But we're not even talking about that. We're talking about just identifying who the people are that have it. Hopefully there was a thinking that once we do that, we can roll it out for all other illnesses. So hopefully there was that. But it was more, there wasn't really an overall here, this is what we want to see, and this is how we're going to get there. And it requires some significant leadership to be that bold and say here. But I know there are people in a number of different senior positions in the government, certainly in privacy and so on, that promote the concept of moving information around so that patients can get comprehensive access. I haven't heard a vision that has been as mature or developed recently to compete against it. So why aren't we embracing this? That's a good question. But part of it is the question that Dominic raised in making innovation. But, sorry, but the final point really is the people that are at Queen's Park take the marching orders from you. Really. That's all it is. It's just us. We are the payers and the users of the healthcare system. If we create enough grief, and I'm going hoarse trying, you have to address it. You have to fix it. You have to. And I think that will fundamentally change the way healthcare is delivered to the point where patients are empowered, they're able to learn and grow and to manage their healthcare, and there will be more time for acute care episodes and wellness management as opposed to chronic disease management that's happening right now.
Question from the web?
How does NextJ correlate different patient records from different domains, lab, imaging, cardiac, etc., for the same patient together? Most of the time, these different domains have different registration procedures and assigns different patient identifiers for the same person.
Excellent question. Okay, my background, as mentioned before, is in banking and in credit. For a very short period of time in 1987, the banks tried to get the SIN number of everybody. I don't know how long it lasted, but it wasn't a year for sure, it was a few months. Pushed back and they stopped that. The idea was so that I could uniquely identify Kevin Leonard that lives in Toronto versus Kevin Leonard that lives in Ottawa or whatever, and have a unique identifier. If there's one thing computers can do, it's read zeros and ones. Because of privacy, because of those issues, they weren't able to roll that out. So what happens is they create very advanced, very complicated algorithms to take name, address, birth date, and a few other things in all different possible permutations and formats to help identify the person. Their accuracy is somewhere around 98%. One could argue in healthcare, well, that's not good enough. It's going to be 100%, especially if the patient's unconscious. We do have a unique identifier. It's called the OHIP number or the healthcare number across the country. This is the question we've got to be asking people. There are projects that create a unique patient identifier. How effective they are, how widespreadly implemented they are questions that need to be answered. But if the patient body is for having access, then I want to make sure it's access to me and only me. I don't want to get somebody else's file mixed up with mine, just like they don't want vice versa. I don't mind having someone having I don't mind if it's all linked together with OHIP number. That's me, but that kind of discussion needs to happen. And if it's not that, then how do we come up with something that is equally effective? But we don't even have that discussion. We're trying to raise that in terms of importance.
I think we have time for one final question. Oh, over here.
Hi. How many hospitals are interested in your idea, hospitals? And why do you think they will join your plan? Thank you.
Okay, I'm sorry, I didn't really hear it.
How would hospitals be part of your idea, your vision?
Yep.
And how would they get involved? Was that sort of your question? Why do you think that they would?
They will.
Like, what's the motivation?
Motivation, yeah.
Oh, yeah. Okay, great. So patients are seen by a number of different care providers in a number of different settings. But we can classify them in one of two places, within the hospital, outside the hospital. Okay, that could be in the home, could be in the doctor's office, wherever. Right now, what's in the hospital databases does not talk to what's in all these other clinics. And very often, what's in all these other clinics don't talk to each other. There's some exceptions, but by and large, that's the answer. So when you're a physician and you see a patient on an ongoing basis, And then the patient comes in and says, you ask him what's new, and the patient says, well, I just was in the hospital for 3 weeks. I didn't know that. What did they do? Oh, I don't know what they did. And so what do? Tries to get phone 2.5 FTEs later, they're trying to piece together what happened in the hospital. So someone that's in a clinic definitely, or doctor's office or whatever, definitely wants that integration. On the same side, though, is the patient that's in the hospital. I wonder, your blood pressure is really high. Is this what it is normally? I don't know. How do I get that? It seems that whenever you really need information, it's Friday night at 6:04. I don't know why, but that's why it is for me. That means the longest time I have to wait till 9 o'clock Monday morning to get it. So it doesn't matter where you are. If the system's fragmented, it's fragmented. And that means everybody gains from better information. You cannot be worse off. Cannot be worse off with more information. Maybe it doesn't add value, but you can't be worse off. So let's enrich the decision-making process by supplying better information in the form of decision support, alerts, and so on.
I think what Kevin demonstrated in his slides, that patient safety would be improved, and that has to be a huge motivator for any hospital. I think there's a comment from the web.
From Dominic. I too am a believer in positive impacts of technology, but systematic reviews, for example, Garg and Haynes, only find some impact on processes, not on patient outcomes. Do we in fact have high quality evidence of patient outcome improvements?
Yes. Well, actually,
think
tell
so.
Dominic I'm sending him the link, because there's an article just came out in JAMIA.
And with that, I guess we
I don't know where you're pointing, but wherever you're pointing, I point back.
I think the audience, some members of the audience have more questions, and I would invite you to come down and discuss your questions with Dr. Leonard and other members of NextJ that are here. Oz is here, as well as Lori. So please do stick around for a little bit of time. But before we leave, I must give what was going to go to Bill, so he's going to be very jealous, but you are now the recipient of a token of our appreciation, so thank you for coming today. And please come back and see us on November 24th. It's going to be a very exciting seminar with a couple of announcements that I think everybody would want to be part of. The first ever Health Informatics Medal will be awarded to the first recipient, and we're just really excited to have that take place here in Waterloo. So thank you for coming today, and we'll see you next month.